Thank you very much for making the time to join this webinar today. My name is Marie Gormley, and I'm a postdoctoral fellow at the NYU Rory Myers College of Nursing. The title of this presentation is Exploring the Effects of Genomic Testing on Fear of Cancer Recurrence Among Breast Cancer Survivors. This work was part of my dissertation, and today I will be presenting the quantitative findings from the questionnaires used to assess fear of cancer recurrence and other psychosocial variables in the study. The findings from the qualitative interviews will be presented at another time. Before I begin, I would like to take the opportunity to acknowledge the members of the study. Thank you to Drs. Melkus, Oizerat, Vorderstrass, Knopf, Hammer, and Fletcher for all their guidance and support. Furthermore, thank you to the National Institute of Nursing Research for funding this study. And most importantly, thank you to the Love Research Army and all the participants. Without your participation, this study would not have been possible. To begin, I'm going to provide some background information on breast cancer. Breast cancer is the most common cancer among women. Approximately 1 in 8 or 13% of women in the US will be diagnosed with breast cancer in their lifetime, including approximately 276,000 in 2020 alone. Notably, there are approximately 3.8 million breast cancer survivors currently living in the US. The estimated 5-year survival is 91%, and this study focused on women diagnosed with hormone receptor positive breast cancer. Among this population, the late-term risk of recurrence ranges from 10 to 41%, depending on factors such as nodal involvement and tumor grade. Cancer survivors face physical, psychosocial, and financial consequences of a cancer diagnosis. Among breast cancer survivors, a systematic review identified fear of cancer recurrence, or FCR, as the greatest unmet psychosocial need. According to the National Academy of Medicine, the survivorship period is often dominated by fear of cancer recurrence, which is defined as fear, worry, or concern about cancer either recurring or progressing. Over half of breast cancer survivors experience moderate to severe fear of cancer recurrence, with rates up to 70% among young adults. Higher fear of cancer recurrence has been associated with greater psychological distress, anxiety, depression, perceived risk, and poorer quality of life. Particularly concerning is its association with dysfunctional behaviors, mental health disorders, and functional impairment. Disease surveillance measures, such as healthcare provider visits, are associated with higher fear of cancer recurrence. However, its association with genomic testing, used to predict the risk of recurrence and the benefit of adjuvant chemotherapy, is poorly understood. One example of a genomic test with the purpose of predicting the risk of recurrence and the benefit of adjuvant chemotherapy is the Oncotype Dx test. The Oncotype Dx test is a genomic test that analyzes 21 genes of an individual's breast tumor among women with hormone receptor positive breast cancer. The tumor specimen is collected during surgical removal of breast cancer, such as lumpectomy or mastectomy. Test results are then reported as a recurrence score, which ranges from 0 to 100 and is divided into 3 categories of risk: low, intermediate, and high. These categories are used to predict the benefit of adjuvant chemotherapy and the likelihood of a 10-year distant recurrence. Therefore, treatment recommendations are specific to each risk category. Patients in the low risk category with scores less than 18 receive endocrine therapy only. Individuals in the intermediate category with scores 18 to 30 receive endocrine therapy plus or minus adjuvant chemotherapy. And those in the high risk category with scores greater than 31 receive endocrine therapy plus adjuvant chemotherapy. Of course, there are clinical variations that are discussed with one's medical team, but these are the general guidelines. And clinical recommendations for the intermediate group were previously uncertain until recent findings from the Taylor-X trial in June of 2018 reported that among women with a recurrence score between 11 and 25, adjuvant chemotherapy plus endocrine therapy is non-inferior to endocrine therapy alone, thus enabling a portion of women to potentially avoid chemotherapy. Another important note is that the test is part of standard care guidelines through the National Comprehensive Cancer Network and covered by insurance. However, despite its clear clinical and economic benefits, the psychological sequelae of genomic testing to determine the risk of recurrence is poorly understood. Therefore, the problem addressed by this study is that the association between genomic testing and FCR is poorly understood. It is unknown if FCR and related psychological stress is more likely to be based on factual risk of recurrence, such as information provided by the Oncotype Dx test, or an individual's existential fears that are independent of factual risk. Since few studies have examined the psychosocial effects of genomic testing, this study addressed a significant gap in the literature. The objectives of this study were to, 1, examine the association between Oncotype Dx test results and fear of cancer recurrence, health-related quality of life, psychological distress, anxiety, depression, illness representation, and perceived risk. 2, determine if sociodemographic and clinical characteristics such as age, income, education, and marital status are associated with fear of cancer recurrence. And 3, to explore whether sociodemographic and psychosocial factors predict fear of cancer recurrence. This study was guided by Leventhal's common sense model and adapted by Marto and Weinman. The model posits that individuals form a cognitive and emotional representation of an illness and/or threat. As you can see, the cognitive and emotional representation work in parallel to inform coping behavior and appraisal. 7 variables were measured in this study, including fear of cancer recurrence, health-related quality of life, psychological distress, anxiety, depression, illness representation, and perceived risk. Illness representation is captured in this model and has 7 subscales. 1, timeline chronic, which is the perceived chronicity of illness. 2, timeline cyclical, the perceived cyclical nature of illness. 3, consequence, perceived consequences of illness. 4, perceived control over illness personally, and perceived control over illness through treatment is 5. 6, coherence, individuals' understanding of their illness. And lastly, 7, emotional representation, which the individual's emotional response generated by the illness. Finally, this model was adapted to capture perceived risk. For the purposes of this study, cognitive representation of illness was captured by measuring perceived risk in the following illness representation subscales: timeline, control, and coherence. Representation of emotion was captured by measuring fear of cancer recurrence, health-related quality of life, psychological distress, anxiety, depression, and the emotional representation of illness representation. This study focused on the portion of the model highlighted in red. This study was what we call a descriptive cross-sectional design. This means that we were capturing women's experience at one moment in time. The sample included women who received the Oncotype Dx test for stage 1 to 3A hormone receptor positive breast cancer, were 18 years of age or older, and who, if prescribed, had completed adjuvant chemotherapy and were currently prescribed endocrine therapy. Participants needed to be able to read and understand English and be capable of providing verbal consent. Women were excluded if they currently had a psychiatric diagnosis, such as schizophrenia or bipolar, had a history of other primary cancer and/or breast cancer recurrence. The following measures were used for quantitative data collection. Fear of cancer recurrence was measured using the Concerns About Recurrence Scale, or CARS. This includes 30 questions that capture the more multidimensional components of fear of cancer recurrence that are specific to women with breast cancer. This includes overall fear and worries related to death, health, womanhood, and role. Overall fear is ranked on a scale of 1 to 6, and death, health, womanhood, and role worries are ranked on a scale of 0 to 4. Health-related quality of life was measured using the PROMIS Global Health Tool, which was developed by the National Institutes of Health and captures overall health by evaluating pain, fatigue, physical, mental, social, and overall health. Scores were reported as mental and physical health-related quality of life. The distress thermometer is a 1-question scale, and a score greater than 4 indicates a clinically elevated level of distress. The Hospital Anxiety and Depression Scale, or HADS, was used to measure anxiety and depression. There are a total of 14 questions, 7 are for anxiety and 7 are for depression, with scores ranging from 0 to 21. 0 to 7 is considered normal, 8 to 10, borderline abnormal, and 11 to 12, abnormal. Illness representation was measured using the Illness Perception Questionnaire Revised, or the IPQR. Of the questions analyzed for this study, there are 50 statements about illness. For example, one statement is, my illness has major consequences on my life, or my illness will improve with time. Scores are ranked on a 5-point scale, and the components of illness representation examined in this study are those discussed in the model previously, which include timeline, chronic, timeline cyclical, personal control, treatment control, consequences, coherence, and emotional representation. Perceived risk was measured with the following question: what do you think your chance is of breast cancer recurring or spreading to other parts of your body, from 0 to 100%? All measures were collected using REDCap, which is a secure database used to collect questionnaires. Data analysis began with descriptive statistics. This means we captured the mean or the average age and so forth. Objective 1 was to examine the associations between psychosocial outcomes and the recurrence score category, low, intermediate, or high, as well as the association with the Oncotype Dx raw score, so ranging from 0 to 100 scores. Analyses were completed with either analysis of variance, ANOVA, or Pearson's correlation. This means that we looked for differences in fear, health-related quality of life, anxiety, depression, perceived risk, and illness representation between the three groups, low, intermediate, and high. An example of what we were trying to capture here is whether women in the high recurrence score category had higher fear, or whether higher Oncotype Dx scores were associated with higher fear. We looked for statistical significance in the analysis, measuring that there was a difference between these groups that were just beyond chance. Objective 2 was to determine if sociodemographic and clinical characteristics are associated with FCR or fear of cancer recurrence. Depending on the variable, this was calculated using either Pearson's correlation, t-test, or an analysis of variance or ANOVA. Essentially, we were interested in whether there was an association between fear of cancer recurrence and variables such as age, chemotherapy status, and education. So an example again here would be, is age associated with higher fear? Objective 3 was to explore which variables can be examined to predict an individual's level of fear. To this extent, a multiple linear regression with block entry of predictors was conducted. So for example, does an individual's perceived personal control of their illness predict their level of fear, or does an individual's anxiety predict their level of fear? A total of 110 women participated in the study. The sample mean age was 57 years, with an age range of 28 to 79 years. The breakdown in recurrence score categories were similar to those seen clinically. Approximately 50% were low risk, 30% intermediate risk, and 15% high risk. Participants were represented across 33 states. Below is a summary of the most relevant descriptive statistics. As you can see, the sample was majority non-Hispanic white, married or partnered, with a college or graduate degree and an income greater than 100,000. Future studies will need to look at a more heterogeneous sample in order to better understand fear across different race, ethnicities, education, and income. Clinically, the majority of participants had invasive ductal carcinoma, stage 1 disease, and were treated with radiation therapy and lumpectomy, but not chemotherapy. A major finding from this study was that higher fear of cancer recurrence is associated with poorer psychosocial outcomes, which is consistent with the literature. As depicted in this figure, overall fear was significantly associated with greater psychological distress, greater anxiety, depression, perceived risk, and lower mental and physical health-related quality of life. Higher overall fear was also significantly associated with illness representation, including a greater perceived consequence of breast cancer, perceived cyclical and chronic nature of breast cancer, and perceived poor control of breast cancer with treatment, and lastly, a greater emotional response generated by breast cancer. The letter R to the right of each of these variables is the correlation coefficient and shows us how strong the association is between overall fear and the variable. So for example, the variables with the highest correlation were distress, anxiety, perceived consequences, and emotional response generated by the diagnosis of breast cancer. Another major finding from the study is that younger age is associated with poorer psychosocial outcomes. This is consistent with the literature, which suggests that the most consistent predictor of high fear of cancer recurrence is young age. As depicted in the figure, younger age was associated with clinically significant higher fear of cancer recurrence in all fear subscales. So overall fear, death, role, womanhood, and health worries. Furthermore, younger age was significantly associated with greater anxiety, lower mental health-related quality of life, and greater perceived consequences and a greater emotional response generated by breast cancer. This table describes the findings from Objective 1, which examined the association between Oncotype Dx recurrence score category and mean psychosocial outcomes. As you can see, the findings are reported by the dependent or outcome variable in the first column and the mean scores for low, intermediate, and high recurrence score category in the subsequent columns. I will share the final publication with those interested, but for now, I am including the outcome variables with a significant p-value. This means there was a statistically significant difference in scores between the recurrence score categories. The first was overall fear. The total mean score was 3.33, which is measured on a Likert scale of 6 and considered clinically to be moderate. Among women with a low risk, the mean score was 3.03. And among women with a high risk score, the score was 3.98. So approximately 1 point higher. The p-value was 0.013, which because it is less than 0.05, means these scores are different beyond what we would expect from just chance. The second finding was illness representation and consequence. The mean score was 19.36, which is out of a total of 30. Among women with a low risk of recurrence, the mean score was 18.39, and among women with a high risk of recurrence, the score was 22.07. The p-value was 0.034. Therefore, women with a higher Oncotype Dx score had significantly higher overall fear and perceived greater consequences of their breast cancer compared to women with a low risk of recurrence. Objective 2 explored the demographic and clinical characteristics associated with fear of cancer recurrence. The main finding, as previously discussed, is the association between fear of cancer recurrence and age. Younger women had significantly higher overall fear, death, health, womanhood, and role worries. Furthermore, women who received radiation therapy had significantly higher health and womanhood worries. Among women who received chemotherapy, women reported significantly higher overall fear and death worries. Finally, womanhood worries were greater among women with a lower income. Other variables such as education, marital status, cancer type, surgery type, endocrine therapy, and time since diagnosis were not significantly associated with fear of cancer recurrence, which is consistent with systematic reviews that report no association or mixed findings. Finally, I'll discuss the findings from Objective 3, in which we conducted a statistical method called multiple linear regression to explore significant predictors of overall fear. We entered 6 predictors using a method called block entry to explore the best predictors of overall fear. Essentially, we explored which factors may be used to predict which women are at risk for greater fear. Significant predictors in the final model were anxiety, emotional representation, and consequence. This means that anxiety, the emotional response generated by breast cancer, and perceived consequences, all three, were the best predictors of overall fear. So in summary, the important findings are that modifiable factors such as anxiety and illness representation are the best predictors of overall fear compared to non-modifiable factors such as age, Oncotype Dx score, and receipt of chemotherapy. This is important because it means that modifying these factors could potentially be used to decrease the risk of developing high fear of cancer recurrence. To summarize the findings of this study further, higher fear of cancer recurrence was associated with poor psychosocial outcomes. Younger women in particular were vulnerable to poorer psychosocial outcomes and greater fear of cancer recurrence. With respect to the Oncotype Dx test, breast cancer survivors with a high risk of recurrence reported overall higher fear and greater perceived consequences of their breast cancer. However, the best predictors of individuals at risk of higher fear of cancer recurrence in the study were anxiety and illness representation. The strengths of the study are that important knowledge that fills a gap was obtained from a geographically diverse sample. Furthermore, the sample was adequately powered to detect significant findings with a final sample size of 110. The main limitations to the study are that the sample included primarily non-Hispanic white women with a high level of income and education. In addition, genomic literacy was not assessed, so we cannot determine how this may have biased the results. Finally, clinical outcome was dependent on self-report and therefore cannot be verified by electronic medical record. This study contributes to our understanding of the psychosocial response to genomic testing and suggests that although women with a higher risk of recurrence may report higher fear, modifiable factors such as illness representation and anxiety may be the best predictors of fear compared to non-modifiable factors such as age, chemotherapy, and Oncotype Dx test results. The significance of these findings is that we can better understand who is at greatest risk for developing fear of cancer recurrence, but also how we might begin to develop targeted interventions to address, for example, illness representations that may be maladaptive. In regard to screening, this study highlights the importance of screening measures for fear of cancer recurrence and maladaptive illness representations during follow-up visits. Brief measures include the Fear of Cancer Recurrence Inventory Short Form and the Brief Illness Perception Questionnaire. Finally, maladaptive illness representations are modifiable and, if targeted, may improve psychosocial outcomes. There are many important next steps to build upon this research, and I will talk here a little bit about potential future directions that I'm currently exploring. Literature on fear of cancer recurrence suggests that it may be important to look at cognitive processing. An example of this would be examining the belief that worry is helpful to, for example, better prepare for a potential recurrence. Other factors include perceived vulnerability. One example is previous loss to breast cancer and an individual's lack of information about how to monitor for signs and symptoms of a recurrence. Furthermore, the literature suggests that fear of cancer recurrence can contribute to maladaptive coping. For example, self-focused attention, rumination, control, and avoidance and/or suppression or worry. Health disparities are going to be very important to assess. There is little evidence about how fear of cancer recurrence varies across race and ethnicity, but there are significant disparities in breast cancer survival. Black women have a 40% higher mortality compared to non-Hispanic white women, and I would like to explore how psychosocial sequelae could contribute to this disparity. Proposed interventions based on this model include a psychotherapeutic and educational component in which survivors are equipped with skills to live with uncertainty and allow them to move forward in their life, such as mindfulness training. An example here would be altering the habitual response to intrusive thoughts to address the individual's processing of their thoughts rather than the content of their thoughts. The rationale here is that some element of fear of cancer recurrence is a normal response, so managing the thoughts so they are not debilitating is important. Ultimately, this is the beginning of my research career as I'm embarking on a postdoctoral fellowship. So there are many directions to explore that will hopefully make a meaningful contribution to cancer survivors. So thank you very much for your time. I am happy to answer any questions or comments. You may contact me directly at the email address shown here, M as in Mary, G as in go, 1847 @nyu.edu. Thank you again.